Your questions are welcome, and this will be monitored through the Q&A panel or through the chat panel. If you'd like to speak directly with our distinguished speakers, just raise your hand. Now, I'm honored to introduce Professor Nelsey Zanon to start our scientific sessions.
Good morning, everyone. Thank you very much, Professor Nasser. It's a privilege for me to be here, and we will share some experience with you and hope everything will be fine and we can transmit and try to answer your questions. Okay, I'm sharing my screen, and are you seeing my screen right now? It's okay for you?
Yes.
Perfect.
Perfect.
Okay, thank you very much. I'm work also at university, Federal University of São Paulo, and Professor Ferris Shaddad just became the host for hosting vascular neurosurgeons by the World Federation of Neurological Surgery for the next year. Is the pandemic gift for us. And the first lecture will be about the simulation and decreasing learning curve for the pediatric neurosurgeons. On this time is a critical period. We have the society not agreement in all of the matters, even in science. And like as surgeons, we need to have some possibilities to try to give back for the trainees for the next year and next future, for they don't lose much experience on this time. The impact in training was cancellation of the routine, no elective surgery for 6 months in some countries, and some trainee goes to pandemic frontline, and fear to contaminate family, and what the next year, we don't know. We are maybe ending, but we are not sure. And at the present, we have a lot of virtual learning like we are doing now, but is enough to replace the hands-on clinical experience? Probably not. We have plenty of online meeting every day, but we need to think that we are surgeons. We need to training our hands to be a good surgeons. And there is a lot of papers about surgical education on this time, but it's quite sure that online learning will stay with us for a while, if not forever. But it's a task force we need to build for the next future. Government in several levels, institution, the society, the medical association, like you are doing right now, the Egyptian society and also the African society, and combine with hospitals and physicians, and try to recover this period and rebuilding facility together, not only for training our surgeons, but also to treating the population that are waiting for our advice. And the current crisis just show us the global inequity in the health service for children in low and middle income country, just shows more the difference that we already knew before. And we have a paper in this neurosurgical focus telling us that the skill-based training model for neurosurgery is a low resources health system. In low resource health system can be a possibility for us to decrease the learning curve for our colleagues. How we can do it in maybe local training centers, try to build a surgical simulation and maintain the theoretical activities online at the same time. And about the simulation in pediatric neurosurgery, I have the privilege to work with Dr. Gisele Coelho, and maybe when this period will end, we need to work even more in this field. We have a lot of different kind of simulation, but the cadaveric specimens is difficult to replicate the pathology and have the restriction to use in some countries. And the animal models is very expensive. We have a lack of reproducibility and poor similarity with the human tissue. And the virtual reality came to help, but is a high cost at the moment. And we don't use the real instrument at the moment to train. And maybe the option is try to mix this reality and try to combine the virtual and the physical simulator. We have been working in two different simulators, in craniosynostosis and neuroendoscopic simulator. Combine virtual simulator in three-dimensional view. The trainees see online and visual the simulator that he will work afterwards in the real simulator. This is how the trainee can see the virtual simulator for hydrocephalus before to going in the real simulator. Planning, viewing, and doing the third ventriculostomy in the real simulator. But before he can see step by step how it's made in the simulator, and can decrease even the curve to see in the simulator, because he's already seen the choroidal plexus. We can see in sagittal view the Fogarty go in, the mammillary bodies, the basilar artery, and we can even coagulate the choroidal plexus on the simulator. And we have here some views that we can see, and here is the physical simulator, and here is the set to do the third ventriculostomy. And the real simulator, we can exchange the head and maintain the same body and lower the cost, just changing the head. But in this head, we can work maybe 10 or 15 times. And this simulator is compatible with CT scan. It's even better if you can see what we are doing. Here is the physical simulator. We see the choroidal plexus, the thalamus striate vein, the septal vein, the mammillary bodies, the floor of the third ventricle. We see already did previously one third ventriculostomy. Here is some retractable tissue, and we can perform this third ventriculostomy on the simulator. And we can see here, just inflate the balloon to see how we can see in the real surgery. We are working with a helper. Usually we are the surgeon with a trainee, and you can find the basilar artery and maybe see some blood inside if we do some mistakes on the simulator. We can also put some tumors on the floor of the third ventricles, or we can put on the pineal region, and the trainee can be training, taking piece by piece and try to simulate a biopsy with his professor or a neurosurgeon on the trainee course. Here is the Craniosynostosis Simulator. We choose at the past the first scaphocephalic patients because it's the most common, and usually even the adult neurosurgeons do this kind of craniofacial surgery, and the simulator can be trained also on endoscopic surgery for scaphocephaly. In our special country, usually we doesn't do this kind of procedure, or is very, very few colleagues that perform. And just to show that we can simulate the surgery in the simulator like in the real life. It's important, and the view we have through the endoscope and taking the bone piece by piece to end. And here is the virtual simulator, like we see. Before do this training on classical technique or H-Rainier technique, the trainee can see on virtual way how is doing on the simulator before to going. We choose this technique because it's the most used maybe in the first 6 months of life. The trick here is try to perform the lateral part of the surgery before. We just decrease the venous blood, and is after this we perform the green stick fracture, and just at the end we perform this last piece on the sagittal bone to prevent or with taking care for the sagittal sinus like we see here. And the end we just fix with absorbable plates. Here is the simulator in the theater, in the operating room. We just do the surgery with the same material that we use in a real case. And we can plan the position of the simulator, and step by step we can see on the physical simulator, we can touch the skin. We go further and find even some blood here. And we see after the exposure of the bone, we can do the same steps we saw in the virtual. We can see in the real simulator doing bilateral green stick fracture, and at the end the H-Rainier, the middle part, and fixed with absorbable plates in the simulator. And also we can close the skin. On this case is the simulator, the head of the simulator is only for one surgical procedure. These models was validated in a scientific way with all the steps that required for a new technique. And the virtual simulators also was submitted to experts to validate and answer these questions. And during the course we did here with international invited speakers was validate the physical simulators with CT scan with no ethical objections, and all the steps was doing on this period. And the level 1 of evidence the simulators used to improve the OR performance on the neurosurgeons. And here we see the simulation with the trainees during the procedures, and the neurosurgeons just looking at. And this paper, we saw that with several times the trainee can do the same procedures, we lower the possibility of the error in these surgical procedures. And Giselle was the cover for child's nervous system with this work that we did here in Brazil, and also with Benjamin Worf collaboration on this paper. And there is a book in simulation on pediatric neurosurgery, but at the moment only in Portuguese. Apologize, maybe in the future we can translate to English or to another language. And Giselle Wynn, the Young Neurosurgeon World Federation in 2015. We doesn't do this work by ourselves. We have a lot of collaboration at the university with engineers, with artists, and we may see is like a baby. And we did the first World Federation course on hydrocephalus here in São Paulo in last year, with the privilege to have physically Professor Maurice Schux and Professor Ezio Di Rocco, with a very successful course, presential, with virtual reality and also physical reality. And the other option is 3D printing models. There is already a paper that the surgery time reduction is 1/3. The better preoperative plan is almost 25%. We decrease surgical complication. We decrease blood loss transfusion, and time also, anesthesical time. And the errors reduction is transform our surgery in a safe way and decrease morbidity. At this moment, we are working with medical students in craniofacial. They can participate on the planning and can see the anatomy before surgery. And the next step we are already working on it is a hybrid models, is a promise to also accurate morphology, a reliable anatomy, like we see here is the patient, and here is the simulator in hybrid myelo meningoencephalocele case. We see the rebuild on 3D, CT scan and MRI to plan this surgery. And you see a lot of people working on it, and already published also with this young group. And now the new steps we are working on the mobile is planning with augmented reality. You can try to see in your mobile to show the families the real pathology, the real case, how look like the child and the CT, and how will be our planning to do the surgery in a safe way and in a shorter time to help this. How we are learning. Resilience in healthcare system is necessary. Integrity of science. Global health institution maybe help us to cross these difficult times with empathy and equity. We know is a lot of technology, but we believe that with more we are using, maybe we can decrease the cost for these materials. And my message is maybe simulation is a very important alternative for this challenging time, and try to decrease this learning curve. It's very important for this moment when we are not 100% working on it. And be able to change our plans and to deal with the life bring to us is a human capacity, and we need to apply our intelligence on it. I invite you, for those that do operate patients or do pediatric neurosurgery, to become a member of ISPN. There is a free ebook you can consult online. ISPN guide is very useful. And I always thank my mentor, Maurice Schux, that is really honor and privilege to be a mentor for him. And finally, what we think we create, what we feel we attract, what we believe become reality, what not believe in a better world, and try to do our best to achieve this final message to you. And thanks for your attention.
Thank you very much, Professor Nelsey, for this great talk. It's very important talk, especially at this time of COVID-19 pandemic. We really need this type of this new type of education, neurosurgical education, and everybody is expecting that it will be more used in many centers all over the world. Let me welcome Professor Dr. Sharif Izzat. Professor Sharif, are you here? Dr. Sharif Izzat?
Yes, Dr. Nasser.
Okay, let me welcome Professor Sharif Izzat. He is Honorary President of Egyptian Society of Neurosurgery, Honorary President of the Pan-Arab Neurosurgical Society. He is former Second Vice President of the World Federation, and he is currently the chairman of the nomination committee of the World Federation of Neurosurgical Societies. I think you'd like to make some comments about.
Yes, actually, I'm very, very impressed with the talk of Dr. Nelsey. I think that this is what suits our time now, and we have to work on it, hoping to get rid of this pandemic as soon as we can. But for the time being, this is the only way to raise the standard of all our candidates.
Thank you, Professor Sharif.
May I have comment, Dr. Nasser?
Yes, go ahead, please, Omar.
I would like to thank Dr. Nelsey for this very interesting topic. I have two comments. You showed us two different types of simulation. The first one is the physical simulator, and the second is the virtual. Regarding the physical simulator, we hopefully invent cheap simulators here in Egypt, and we use it in our courses in collaboration with the Egyptian Society since 2016 till now. However, regarding the virtual, it's quite fantastic. It's quite, I think it would be cheap or expensive, and how we could obtain these. And is it is any surgeon can feel the sensation or not? Could you please show us in details a little bit? Thanks.
Thank you, Professor Omar, and congratulations for doing already this course. This is very important for the young to start with hands-on, with this feeling that the physical simulator really decrease the fear to fail on the operating room. And the virtual simulator was doing in the doctorate at university. It was the group of engineers, of the technician in the I forgot the real name in English. The technician in the TI that work, they came to us, they see the real physical surgery in the real simulator, and they build virtually step by step. I couldn't imagine that, for example, 1 minute video took for them to build several hours, if not several days, to build this virtual simulator. Probably with technology and with more young people going on the field, we can decrease this time to build a virtual simulator. Probably we have now faster technology, a lot of improvement on this field in these pandemical times. And maybe we can decrease this time to build this virtual simulator and be available for more people and doing course with this for everyone, I hope.
Thank you, Professor Nelsey. Any other comments before we proceed to our next speaker?
Yes, please, Dr. Nasser.
Professor Sharif, please go ahead.
I'd like to ask you, Professor Nelsey, do you think that regarding the expenses, which is usually high to do the simulation, do you expect that the AR technique will go is going to be with a lower cost than the usual simulation?
Yes, I believe if we just look back maybe 5 years, 3D printing models, it was almost impossible for us to afford with this simulation. And now you can have a 3D printer in your office almost. Really, the technology came with a lot of force, and I think it's for the bad or for the good, depend of human being choices. And if we focus for the help other people's, probably we can do better than we are doing now. A lot of improvement in the last 5 years, lower cost with 3D printer. Physical simulators, not yet, but sure, we will find a way to have reproducibility on this simulation soon.
Thank you.
Thank you very much. I think now we proceed to our next speaker, Professor Omar Hamed is going to speak about tips and tricks in transventricular endoscopic surgery.
First of all, I would like to thank Professor Nasser for his kind invitation and for his dedicated effort to achieve these and those webinars. Now we are in the 28th webinar during this pandemic. I would like also to welcome our distinguished eminent Professor Dr. Nelsey. Great welcome, and it's our great honor and pleasure to join us in this webinar. I would like to welcome our great Professor Sharif Izzat, is our great professors and our mentors in the neurosurgery, and welcome of my colleague, the Professor Dr. Ihab Rifai.
Thank you, Omar.
I'm sharing the screen now. Is it okay?
Yes, it's okay.
Good. My talk today about the use of different transventricular endoscopic techniques, especially for the genius to show them the tips and tricks how to deal with the different pathologies and different issues in this challengeable aspect. We should all of us know, and we must know the CSF circulation. It's quite important to know the CSF circulation from A to Z that give us the idea how to know the pathology, how to deal with the pathology, how we choose our decision. However, I'm still convinced with this statement that CSF is still not fully understood till now. All of us know the catastrophe of hydrocephalus. It is a catastrophe for the child itself, catastrophe to the family, catastrophe to the whole community. When we go to in the history, we could see different trials to define the hydrocephalus, to deal with the hydrocephalus. To define the hydrocephalus, to know how to manage the hydrocephalus, as you see here with by the ancient Egyptians, he used the trifine just to evacuate the water from the skull. The others use just percutaneous aspiration. The others use the wrapping of the skull that they thought This will prevent further enlargement of the skulls. However, the shunt still have a lot of problems. All of us know these and those problems. Migration, perforation from a different structures and different organs. All are a catastrophic complication. That's why the endoscopic procedures is quite essential and important to solve those all problems. This study, one I performed on a 200 patient from 1998 to 2004, and another study between 2010 2016 using different endoscopic procedures and techniques. We should know the different shape and the different structure of different floor of the third ventricle. Here, the floor it's quite opaque, and in that situation, it's a little bit difficult that we are working blindly. We are not seeing the underlying structure, especially the vascular structure. In that situation, we should be very careful and meticulous to avoid the injury in cases with opaque floor. However, in the contrast to the quite transparent floor, you could see here the all basilar tree, the cerebral, the cerebellar arteries, and another difficulty here. There is a quite short distance between the basilar tree and the dorsum celli. In that situation, we should pinch the membrane and go to do the fenestration very safely on the bone. The bone is the most safest area to do the fenestration over. That we in that situation you could go away any vascular or any vital structure. As well, you should go to penetrate and fenestrate the liqueous membrane around the basilar and around the perforators. As my mentor, Professor Berneski, said, this is the pocket of the fifth ventricle. When you leave this membrane, you will leave a pocket or a fifth ventricular sac. This is very essential to perforate this membrane to make sure free flow CSF. Another important advantage for the endoscope, you could use it to do either simultaneous ETV with endoscopic shunt insertion to put the proximal tube under the guidance and under the control of the endoscope to avoid the complication of the sticky of adhesion of the proximal tube to any intraventricular structures. It's quite vital option of the endoscope in that situation. Another option to use the endoscope to make an endoscopic biopsy, which is it has the advantage of a good visual control. You take the biopsy under good magnification with good light. You take a good and enough tissue for pathological diagnosis. You could also do simultaneous other endoscopic procedures, either ETV or and put shunt under the endoscopic shunt insertion and control of the endoscope. A very important option for the endoscope in case with Infectious Hydrocephalus or in intraventricular arachnoid cyst. As you see from here, the concept here is to convert the multi-compartmental hydrocephalus into a one compartment. That's a tool to improve the use of the endoscope and solve the problem of the multi-compartmental hydrocephalus. You use the endoscopic bipolar, making a cauterization of the wall, and then using the scissor to open the cyst wall. Then you would open the whole septa until you make sure that there is a free flow of CSF through all compartments. As well, you could use it, the endoscope in case with a colloid cyst. And in the colloid cyst, there is sometimes with a low viscosity material, and the others it has a very viscid materials. In that situation, you should use frequent suction to these materials. You could use, if in cases with the large types, you could use another bare hole with another port to just for suction. And a very important trick here for me and for my when I learn my teach my juniors, I don't use this twisting maneuver of the colloid as the others use. My concept is the twisting of the membrane and the pedicle of the colloid. It make a traction on the roof of the third ventricle and the traction on the fornices, which could may produce injury. The concept in the colloid just to make a fenestration, suction, cauterization, excision with scissors. If you leave a remnant and open remnant, it will not grow again. It will be a very nice event. A very important use of the endoscope when you face a bleeding point. Don't hurry to use the cautery here. The use of the cautery here will make more injury and more bleeding. Here you could just advance the length of the endoscope very gently till you reach the breathing point, and just make a very gentle compression just for 5 seconds. However, you must do it very gently. Any forcible or aggressive maneuver will do a further injury. Here, just very fine compression, gentle compression. As you see here from this video, the bleeding point stopped successfully. The other usage of the approaches, you could use the concept of aqueduct plastic. This here you could this type is a flat type. It's quite easy type that just you touch the membrane with the tip of the Fugate catheter. You could see it's quite opened now with good flow. This F. Here it's a type of the infundibular type. It's a little bit a difficult type. Here I started to use the ATV firstly, then go back to the aqueduct. This is the infundibular type, using the same concept with the Fugate catheter. Very gentle, very gentle, very gentle. The structures here, especially the periaqueductal structures, is quite vulnerable structures. Another case with infundibular type, starting to do the ATV firstly, then I go back to the aqueduct through the infundibular part. You could see here I'm introducing the Fugate catheter very gently, very gently, very gently, and very sensitive. And you have to take this sensation of the Fugate catheter during its introduction into the aqueduct. That's why we should know the anatomy of the aqueduct. It's quite important that the aqueduct, as you see from here, there's a lot of constrictions and a lot of dilatations. It's not a straight canal. Sometimes it has a multiple pictures. Here, Russell classification showed us there are 4 types. Either the stenotic type, where the ependyma obliterate the lumen, and the forking type, and this is the most difficult type, where there is a multi-forks and multi-channels, either connected or not connected to each other. This is one of the most difficult type. Another type, it's the septum type, where there is a web or gliotic structure obliterating the aqueduct. And the last one, and which is a more, it's difficult also, this is the gliotic type with diffuse gliotic structure stenosis, which also one of the most difficult type of a aqueduct. This case, it's 11 years old child, had four failed infected shunt surgeries. At that time, we decided to remove the shunt and to do the ATV. You could see here the MRI after the ATV. You see the site of the cortical incision and the site of the endoscopic port. However, he developed after a couple of weeks, he developed pre-coronal swelling, and this is very important issue to show it for our juniors. When you found this pre-coronal swelling, don't feed up rapidly, and don't turn this case to VB shunt rapidly. Just do the repeated lumbar punctures. I do a repeat lumbar puncture for 3 weeks for this child with a bandage on the site of the swelling. After 3 weeks, the swelling disappeared. The child was quite nice, quite active. However, when I did the MRI, I found that there is no void signal at the floor. This means this is non-successful ATV. Another interesting observation here, this child, although his MRI still not successful ATV, however, this child has a very quite high IQ. He could say his history in quite details with the specific time of date and the time of his symptoms and the date and the time of the different surgical approaches he underwent. Uh, that's why I said, and I am convinced with the statement of the CCF. CCF is not fully stood under until now. Still, there is a mystery in the CCF circulation, not fully understood till now. This my belief and my concept. There is another child, 4 months age, and the circumference of the skull is 46.5. I show advanced hydrocephalus using very essential the heavyweight T2 Fiesta MRI. It's quite important in those cases. We could see here just a membrane obstructing the proximal part of the aqueduct. That's why I decided to go using the ATV plus Aqueduct Plastic with the endoscope. Here, doing the ATV, as you see here. Then go back to reach the aqueduct. It looks as looks as infundibular type. Go very gently with the Fugate catheter, very gently and very sensitive. You have to take the sensation and perceive the sensation in your hands. Now I could see there is a free flow of the CCF through the aqueduct. This is the post-op MRI showing the air fluid level, which indicates the site and the trocar, the port of the endoscopic approach. We could see here a very interesting observations. Here there is a heavy void signal at the floor of the third ventricle, which means a successful ATV. However, there is a faint void signal here and faint CCF here in the aqueduct. I do a CCF fluometry I was astonished that I found he reported there is a hyperdynamic circulation and with very flow dynamic within the aqueduct. From this, I learned that the simultaneous ETV and aqueduct is not a good solution. That's the simultaneous ETV and aqueduct push the CSF to flow through the easiest way, which is the ETV fenestrum, rather than the difficult way, which is the aqueduct. That's why the simultaneous ETV with aqueduct enhance the aqueduct reclosure with intact ETV fenestrum. Another case with 5 month age with NICU admission for 1 month. You see advanced hydrocephalus using the same technique of heavy weighted T2 image. We see here a funnel infundibular type of aqueduct, as you could see here. I took the decision to do aqueduct plasty to aiming to giving back the CSF back to his normal physiological way. This is my concept. I'm trying to do the aqueduct to let the CSF to go back its normal physiological way. Here, as I said before, go very gently. Here, I'm still receiving the sensation at my hands, but at one point, I didn't know I fenestrated all the aqueduct or not. That's in this situation, I don't have any clue or any key to tell me about the successful aqueduct plasty. I depend only on the turbulence of CSF which occur, but still I don't have any guide or any clue to know is it fully fenestrated or not. As all of you know, the aqueduct is passing through the brainstem. Any forcible frustration could be make a quite severe injury. This is the 1 day immediate post-op. The CT scan show the air fluid level. However, after 2 months, this child developed persistent pre-coronal swelling at the side of the endoscopic site. I used a repeat lumbar puncture for 2 or 3 weeks. However, this swelling didn't disappear. When I did the CT scan and the MRI, I observed here that the CSF choose his easiest way, went up through the cortical incision, then went around the brain in the subarachnoid space, making here hello.
Omar, go ahead.
Are
We
you
can
here?
hear your
Are you here?
voice.
Okay. Uh, Here we could see the CSF go around the brain, and he took the easiest way in the subdural space, making like an external hydrocephalus. Another very strange observation you could see here that the CSF partially go through the frustrated part here, and another CSF make another way between the cortex of the cerebellum and the tectum of the midbrain. You see here another way here going to the aqua. That's why this child stayed uneventful for 2 months without any swelling or any problems. This child turned to a VB shunt. It's a failure of ATV. Another interesting case, this is a 34 years male patient, had a chronic moderate headache for more than 6 months with a blurring of vision and the fundus showing an early papilledema. You could see here there is hydrocephalus, could be diagnosed as late onset aqueduct stenosis. This is the heavy weighted T2 Fiesta technique. We could see here a very strange pathology. I decided to go with the endoscope to see this pathology and to do either ETV or Aqueduct Plus. This is MRI. You see here the acute dipping of the curve, which means there is quite absolute obstruction of the aqueduct. I went here through the front row. I will going to back to reach the aqueduct. This is the choroid here. You see it clearly. This is the massa intermedia, as you see. Here, a very strange structure. You see, I think this is angioma. And this situation, I decided to do an ETV as when it would be difficult to deal with this angioma for the horrible bleeding would occur. Only an ETV, I think, would be enough for this case. As you see here, using just twisting mechanism to penetrate the floor. The floor here is a little bit thick and opaque. It's not thin. It's an adult, as you see. And you see now the dancing sign of the membrane, which means a successful fenestration. Try to widen the fenestration by Fogarty catheter until you make sure that there is a free flow of CSF. This is the post-op MRI. You could observe here the quite change in the curve, which all see here a successful ETV. Here the post-op CT showing the air fluid level, then the heavy-weighted T2 Fiesta technique, which show here a very nice voice signal in the floor of the third ventricle, which means a successful ETV. 1 month post-op show still a successful ETV filtration, and this 1 year also still hopefully showing a successful ETV with still the presence of the void signal at the floor. Another interesting case is 25 years male patient. When he came to the casualty at night, he developed repeated convulsions and he went into aconization. And the team at that time, casualty team, prepared him for a VP shunt. They did actually the VP shunt. This is the MRI pre-op diagnosed at that time. It's obstructive hydrocephalus due to the late onset aqueduct stenosis. Unfortunately, 2 weeks later, he developed bilateral subdural hematoma. At that time, we took the decision of ligate the distal tube in the neck, evacuate the hematoma through bilateral burr holes, then do ETV or aqueduct plastic. This is the video clip of this patient. Here we go through the front row. Here the aqueduct. There was a web in the aqueduct, some sort of bleeding, the blood clot. Try to remove it. Then widen the fenestration of the ETV until we make sure there is a good flow. However, unexpected expectation. This is the immediate post-op CT, shows very nice and nothing at all. The patient was very conscious, fully conscious. 20 hours post-op at the early morning, this patient developed acute conization. When we did this CT scan, it showed advanced hydrocephalus. At that time, hopefully, we remove the stitches from the distal tube. Until now, still living very nice way. And this pushed me to raise these questions. What is the explanation of this event? Why this patient withstood the aqueduct stenosis for 25 years? However, he did not withstand the ETV or aqueduct plastic. Still, we don't have answer till now. This table just summarized the success of the aqueduct, still of low success, only 20%, 2 cases out of 10. However, I still have the dream to do a successful aqueduct plasty to solve the problem of hydrocephalus. The study one at that time reported a very low success rate. However, the study number 2 showed us a quite a higher success with 72% success rate, and this could be attributed to the difference in the image resolution, in the instrumentation, and also the use of the repeated lumbar functions. Still, I'm using 10 now, and I think it would add a good success. When you see some papers, a very interesting paper by Malushi in England, he reported there is no guarantee for a successful ETV forever. Even up to 8 years, still there is a 3% of patients require another second procedure. Another paper by Schroeder, he divided the patient 3 groups, group A with ETV only, group B endoscopic aqueduct plasty, group C the simultaneous EDV and aqueduct plasty. He reported there is a reclosure in 50% of patients. My conclusion, the neuroendoscopy becomes no more a new area of interest in the neurosurgery. The transventricular endoscopic techniques offer and introduce a very nice solution to the problem of the hydrocephalus, either the ATV alone or with another procedures like endoscopic shunt insertion or endoscopic biopsy, endoscopic colloid cystectomy, the endoscopic cystostomy in case with cystic hydrocephalus, or endoscopic aqueduct plasty, and finally the endoscopic hemostasis to avoid the use of the cautery. The transventricular endoscopic techniques of procedures reported a different success rate in a 2 different era. I think due to the difference in the instrumentation, the images, the technology, and the use of the repeat lumbar punctures. The endoscopic aqueduct plasty, it offers a normal back of the physiological circulation of the CCF. It could obviate the need for the shunt device. However, it is feasible and easy in case with the infundibular type or flat type. However, in the structure type or S-shaped type or multi-forked, it's quite difficult and absolutely contraindicated. Learning curve, it's quite still important and essential. These our workshops, we do it under the patronage of the Egyptian Society of Neurosurgery in the last years. It is now a dream for all of us to come back these courses and workshops and hands-on. We hope this pandemic ends rapidly and safely to continue our education and continue our scientific events. Thank you for your attention, and thank you for all of you.
Thank you, Professor Omar Youssef, for this very stimulating presentation and very great talk. Thank you very much. And I think we worked together before, and we organized many hands-on workshops about ventricular endoscopy in Egypt. And as you just said now, we hope that we are going to resume our activities again, hopefully after this pandemic will be terminated Now we are opening discussion. If there are any comments or questions for Professor Omar Youssef.
Congratulations, Professor Omar. Very, very nice work. Did you feel that with endoscopy in small baby, we tolerate ventricular megaly much more than we tolerate with shunts? Did you believe that impact in the outcome, this ventricular megaly for long life, or not? Did you feel that even when we treat this small baby with endoscopy is quite well neurodevelopment?
I didn't understand well the question. It's about the ventriculomegaly alone, or about the
No,
obstructive hydrocephalus?
after third ventriculostomy.
Uh, yeah, actually, it's a very important observation for all the surgeons work in this field. Normally and very rarely that the ventriculomegaly went back to the normal after endoscopy. It's not like the shunt surgery. I have a lot of child and a lot of adults. The ventriculomegaly doesn't went back to the normal. However, it's quite normal, quite intact, especially when you see this last patient with this angioma, this 35 years old. The ventriculomegaly is still there. However, the cis MRI and the cis fluometry is quite successful.
Thank you.
Thank you, Omar.
Thank you.
Any other questions or comments?
Yes, please, Dr. Nasser.
Professor Sharif?
Thank you. Thank you so much, Omar, for this very nice presentation. I have actually three questions because it's a very appealing talk. My first question regarding when you can say that a certain case is not suitable for ETP, and at the same time when you decide to revert to shunt surgery in an previously operated ETP patient.
Thank you, our professor. It's our honor to join us, Professor Sharif. The first question, I use the ETB in only obstructive type hydrocephalus, and I have to use both the CSF fluometry preoperative, the heavy-weighted T2 MRI, Fiesta MRI, and the CIS MRI. All these three investigations is very essential to support the diagnosis of obstructive type. They communicate. I don't use the ATV or aqueduct plastic in communicating type, only obstructive type. Regarding the turning to VB shunt, uh, this, as I said, I should do a repeated lumbar puncture when I found a persistent swelling of the wound of the barrel hole at the endoscopic site, or persistent parino or persistent neurological deficit. At that time, I should turn it to VB shunt.
Thank you, Omar. Can I ask you about, I know that
Okay,
your
thank
talk
you.
is, okay, go ahead, please, Professor Sharif.
Yes, I'm sorry, Dr. Nasser, but the second question is about what do you think about aqueductal stenting instead of aqueductoplasty, especially in the cases you faced where you instead of the CSF easy way as obstructed or not wide enough to allow the CSF to pass through it. Don't you think that aqueduct stenting would do more better than aqueductoplasty only?
Actually, I'm not convinced with the aqueduct stenting. It has a lot of problems. It has the problem of penetration, the problem of migration, the problem of closure. It is like a shunt. The same complications occurred in the shunt could and might occur in the aqueduct stenting. That's why I don't convince with the aqueduct stenting. However, Dr. Ihab, I think he will speak on the aqueduct stenting. I think so.
Ihab, let me
Maybe
introduce
Dr.
Dr. Ihab Rifai. He is Associate Professor of Neurosurgery at Cairo University. He is one of the eminent pediatric neurosurgeons in Egypt and the Middle East. Ihab.
I would like to express my deepest gratitude at first to Professor Nasser El-Ghandour and Professor Dr. Omar Youssef for this very kind invitation, and the Egyptian Society of Neurosurgery, and also Professor Sharif Izzat and Professor Zanon for this very fruitful discussion. I think the stenting, as Professor Omar was just talking about, the stenting has a very limited indications, I think, nowadays. Only a stent without connecting it to a drainage device or a shunt, it's very limited now. But for the problem of the penetration and migration, I will try to give some comments in my presentation. I will start now to share my screen.
Thank you. Ihab, still we have our next speaker, Professor Nelsey.
Okay.
Before your talk, she's going to speak about spina bifida prevention.
Okay. Very good. So.
Okay, I'm sharing the screen now. It's okay for you?
Yes, it's perfect.
Okay, thank you. About spina bifida prevention, the aim will be some backgrounds, diagnosis, and also some words about treatment. Since the 19th century, when we see this draw about Jean Corvellier shows how complex is this pathology with Chiari, with syringomyelia, with tetradic cord, and depend on the level of this lesion. And since McLone, we know that maybe myelomeningocele is one of the most complex neurological malformation compatible with adult life. And we have around 300,000 live births worldwide, and around 2.5 per 10,000 live births, and no number of miscarriage, stillbirth, and abortion with spina bifida. The physiopathology, the most accepted theory is the multiple site closure. We see here maybe can explain in some patients when we have two lesion, two spinal dystrophism, or encephalocele and spinal cord dystrophism. More and more, we have precocious diagnosis with this pathology. The ultrasound shows in the spinal cord that we don't have the posterior bone to close this vertebral canal, and the brain can show the classic sign of lemon or banana. But the neurosurgeons are more easygoing and more easy to see MRI, like we see here. We see the myelomeningocele and the hydrocephalus, and the criteria for fetal surgery is usually the Chiari tumor formation. The most common postnatal repair, still the postnatal repair, is most common in every country. We prevent infection and deterioration, but we maintain the deficit of gain, renal, sphincter, and if we have infection, cognitive trouble in this pathology. The classical technique to close myelomeningocele after birth is more or less the same. It's a neurosurgeon preference. Some of our cases postnatal repair in our institution. In my particular case, I prefer this technique is old one on the 70s. I prefer to find a normal tissue to cover this defect, but is a personal choice. If you use this variant is okay. If you not, you have your personal preference. But since 2011, after Moment's trial, we perceive that we can decrease the hydrocephalus and improve the motor and neurodevelopment when the patient is treated in a fetal way. I got the privilege to work in the phase 1 trial with the video surgery to close myelomeningocele in the fetal period, the same criteria on the Moment's trial. And the difference is just cover the defect and close the skin in the first phase of this work. But when we perceive the scar shows some cases of CSF fistula, and the video surgery progress and now close the myelomeningocele without close the placode, but close the muscles. That the first step we didn't. And both techniques shows the improvement on the Chiari in the fetal period, 25 weeks gestation before myelomeningocele closure. We see the small posterior fossa without CSF around, and we see here the CSF come back and enlargement of the posterior fossa. Maybe for me is the most encouraging sign to still indicate fetal surgery. Both techniques need to deal with premature baby, and we need to have a very, very good neonatal care. If not, we can lose some patients for the prematurity that is a pathology by itself. The allergy in these patients can become 25 to 60%. Maybe it's time to start already do latex-free surgery in the fetal period already. The prevention is a global health burden because maybe is the most important preventable cause of infant morbidity and permanent disability. Some risk factors we know is history of previous pregnancy with neural tube defect, or family or parents with neural tube defect increase the risk to have a baby with myelomeningocele. And also there is some gene polymorphism related with this special group of patients. And another risk factor is the anticonvulsants like carbamazepine or valproic acid, also obesity and diabetes type 1. Since the 70s, it was shown that the prevention of this neural tube defect is with vitamin folate supplementation. And the role was shown in 64 when the first evidence came with the relationship between folate and neurotubal defect. In the 80s, the British Medical Council published that 72% of prevention was possible with supplementation of folic acid. And some other studies shows that maybe at least 50% can be prevented with folate supplementation. On prevention, we have two ways to work also in a public health system and like a physician, or food fortification on folate supplementations. Both ways can work together. The folate supplementation is an individual question, is a question of education and awareness. When we are talking about food fortification, we need public policy, Minister of Health and Minister of the Economy working together with the Medical Association. When we are talking about education, individual women need to take folate before conception. In the 90s, the United States shows that less than 20% of women may, even though they receive the awareness, only 20% receive or take the folate before conception. And what kind of food fortification we need to work on it? In several countries, we have rice, maize flour, and wheat flour. There is some studies working in maybe sugar and salt, but is not on the track until now. For us, we need to know that the Minister of Health, the health profession need to work with government and with the resource management, because it's the industry question, but also the public health questions. Here we have the countries that where is the mandatory, the legislation to fortification, flour and rice, 67 countries. Here we have the green is wheat flour and maize, where the Brazil are. We can talk about Egypt during the discussion. The folate supplementation, how we can put how many milligrams. In our law, it's 0.50 milligrams for 100 grams of the product. We see in 10 years before and 10 years after, when it was mandatory in our country, we can perceive that more than 20% decrease the myeloma patients. And if we consider the stillbirth patients, 1/3 less case we see, and we can try to encourage other countries to do the same. The World Federation is on the goals also of the Pediatric Neurosurgical Committee. But if we have already the fortification and the folate, we still have some cases with myeloma. We don't have all the answer, but maybe the woman with neural tube defect have some autoantibodies against folate binding receptors. And maybe the methylation cycle pathway have some genetic knockouts, but we don't have 100% of these answers. And the folate supplementation for the women need to be take 1 to 3 months before conception. But we know that maybe half of this pregnancy is not planned. Is the reason because we recommend for the all period of childbearing age to take this folic acid. And since 2010, the Food and Drug Administration approved the pill with a folate. We don't have the numbers since yet. If we have some positive answers. And these patients become adults in 60 to 75% of these patients. Just for us neurosurgeons to know, we may imagine that these adults will die for infections or for other questions. But we have small papers on this subject, and unfortunately, the cause of that is non-diagnosis V-patient malfunction at the moment. And these patients, 2-year survival rate is more than 95%, and normal intelligence in 7 to 80%. We know for several papers that the intelligence is related to or brain malformations or infection, not necessary with spina bifida patients. The prevention is a medical, in summary, the medical and government and political decision to decrease cost in long term. And myomeningeal repair after birth is still the most common procedure to treat myomeningeal. Fetal repair, the positive aspect, we have reduced hydrocephalus, reduced tonsillar herniation, improvement in motor and neurodevelopment. We have the negative aspect, the prematurity. We need a very good, excellent neonatal intensive care. We need to pay attention for the mother, and some reoperation on tethered cord apparently is more frequent in fetal surgery than postnatal. Is a multidisciplinary team, is a lifetime commitment, myomeningeal patients, and the family is very important to stay with us for life, to take care for these patients. And all the specialists, urology, orthopedists, psychologists, social works, need to work together. And always my gratitude to Professor Schutz, and thanks a lot for your attention.
Thank you very much, Professor Nelsey. It's very, very interesting presentation. Really, actually, we are seeing a lot of these patients. We have a pediatric hospital, which is affiliated to Cairo University. And I think Ihab can say to us how many patients we are seeing every week. We have about 3 clinics, and we are doing a lot of operations. Ihab, would you just comment about the talk of Professor Nelsey?
Thank you, Professor Nelsey, for this very comprehensive presentation. Yeah, actually, in Cairo University, we have like a waiting list. Maybe more than 100 cases are waiting to do the surgery with meningomyelocele, I mean, or myelomeningoceles, and we do like 20 cases weekly.
Seriously?
Yes.
20 myelomeningocele cases a week?
Sometimes it depends. Sometimes
Yes.
we have a special day to do the waiting list, and in this special day we do 20 cases, and sometimes we don't have a special day.
You have a waiting list for postnatal repair, or for hydrocephalus or tethered cord secondary surgery? For primary closure of myomeningocele, did you have a waiting list?
Yes, this is a problem that they, when it's not a ruptured myelomeningocele, we don't have a capacity to do it at the same day of birth, so they have to wait. There's no capacity. And sometimes they wait for a long time, but we try our best that they don't wait for this long time.
Wow. I got this experience 20 years ago when I came back from France. The patients came to our reference hospital 1 month, 2 months after birth, because they wasn't aware about the emergency surgery. And fortunately, we can change sending letters, and they came at the same day. We changed reality for a while. But apparently, your problem is not diagnosis, it's question of numbers.
Yeah, big number of
the
cases.
capacity.
Yeah, big number of
Nelsey,
cases.
what
and
about your center? How many patients you are seeing every week? I know that you are the head of the Pediatric Neurosurgery department. How many patients do you operate every month, for example?
Fortunately, decrease a lot for two main reasons. When maybe 2 or 3 years ago, it was always once a week or 5 to 10 a month. But when the professor of obstetrician just got retired, we slowed down a lot of myelomeniingocele patients. And even we have a lot of other regional hospitals now that taking care locally the myelomeniingocele patients doesn't came to our university. And at the university, I'm not the head of department, is Professor Faris Shaddad, the head of department, and Professor Sergio Cavaliero, the head of pediatric neurosurgery. I'm head of department in private hospitals, just for to be more real. My question to you, you are the leaders in Egypt. The fortification is mandatory in your country. Maize, wheat flour, rice is mandatory to have food fortification or not?
Professor Sharif, would you comment on this?
Yes, no, no, definitely it's not till now.
We may work together.
The government is giving a big effort to do this, but still we didn't reach the optimum to finish with the whole community with this fortification.
If you need help, we may try to combine some, I don't know,
Yes,
webinar
of course.
with the government, try to build economical advantage for the country and try to change the reality, not for tomorrow, but maybe for the next years. Costa Rica is one country that I think in Latin America, they lower increasingly more than in Brazil. In Brazil, we have 20 to 33% lower in 10 years. And for the country and for the family, it's very, very advantageous, this attitude. And here it was the Neurosurgical Society, the Pediatrician Society, and the Gynecology and Obstetrician Society. If you are together, we can try by World Federation, join you and try to push.
Yes,
Okay,
yes.
this is great news, and I think Professor Nasser, as a president of the Egyptian Society, can do this job urgently.
It is very important. It's very important, really.
I can ask to Dr. Adrian Cáceres from Costa Rica, and Kemel is a working force for international societies. We can prepare a speech. They can talk about economical point of view, because if you talk about economy, you can be listened. If you talk about only healthy people and be kind, they doesn't listen us.
Yes, yes. So please give the contact to Professor Nasser, and we can arrange to
with pleasure,
arrange for a meeting for this.
We'll be happy to change your reality.
Yes, please.
And we'll celebrate together.
Yes, it's good news, and I think I will give a big part of this responsibility to Dr. Ihab Rifai as well, because he is already maybe the most senior consultant, or the second senior consultant in the Pediatric Hospital of Neurosurgery, which is a Japanese hospital, and it's affiliated to Cairo University. And so we will be in contact with you, Nelsey and Ihab. We will communicate with each other and try to make some achievement in such issue. Thank you, Nelsey, very much for your willingness to help and to support the pediatric neurosurgery in Egypt.
Pleasure, dear.
Thank you. Professor Ihab Rifai is going to speak now about neuroendoscopic stent placement for CSF pathway obstruction.
Thank you very much, Professor Nasser. Actually, I started working on in the neuroendoscopy subspecialty with Professor Nasser El-Ghandour in the pediatric hospital down in 2007. We started there, and afterwards I went to Greifswald, and I went there. I was there for a couple of years with Professor Schroeder. I learned also a lot from him, and nowadays there is like a cooperation, a very successful cooperation between Greifswald and Cairo University, and we are actually very active in this from the starting of the COVID. We are very active in the online learning programs, and we have also troubles because we are running now a neuroendoscopy training fellowship. And the candidates have to take like a kind of hands-on training, and we had this conflicts about the simulators and the virtual simulators because of the limited mobility at the time being. And hopefully we will start doing an actual hands-on courses starting from next year. So this is only a small introduction, and I will start talking about the stenting in using the endoscope during putting a ventricular catheter. Either this catheter is a stent or this catheter is part of a shunt, of a VP shunt. And if we look in the literature and look actually in our thoughts and beliefs, we don't believe much that looking on the ventricular catheter will just make any benefit more than putting it blindly inside the ventricle when the patient has a very progressive hydrocephalus and the patient that we see in the pediatric hospital. And this is actually proved in literature starting from 2003 in a very big study, and just saying that using the endoscope when putting the ventricular catheter inside the ventricles is not of benefit. It was a large study with more than 300 cases. But actually, if I can comment on this study, we can say that there are maybe two things that we have to take care. The endoscope that they use is the intraluminal endoscope. It's a very small optics, very tiny, inside the lumen of the endoscope. So you don't see much from this. It's still there. I think many companies are still manufacturing this endoscope, but its use is very limited. And the other thing that in this study, it was not focused on the compartmental hydrocephalus. And I think when we are talking about that, we have to take a look while putting a ventricular catheter. So we are talking about a complex hydrocephalus. We are talking about ventricles with many compartments, so that we cannot blindly say that this catheter is passing through all these compartments. So this is my comment on this study. And if we have a look on the recent literature, so we can see that a smaller study published in World Neurosurgery 2 years ago, and it was also talking about this intraluminal endoscope that is passing through the shunt. Very small optic. The vision is not that what we see with the ventriculoscope. Actually, they used this endoscope, but they were talking about trapped horns and compartments, and that's why they saw some success. They saw some difference between putting this ventricular catheter while using an endoscope and putting this catheter without using endoscope. So they saw a difference, and they said that it's better. So this may be a difference. And that's why we, in our experience in Cairo University and also in Greifswald, this is a technique that we use. We use normal ventriculoscope, either the stores, this Lotta endoscope. This is a standard that we are using now, either the Lotta or and the ventricular catheter is passing beside the endoscope with a special technique. So maybe most of us are using this technique, but just trying to define this technique in this presentation. And as we said, we are dealing with multiple locules, as Professor El-Ghandour published maybe in 2008 about the multilocular hydrocephalus in pediatric GNS. So what is the aim of the stenting technique, or endoscopic stenting, or endoscopic visualization of the ventricular catheter? Is to connect all compartments together, either to a drainage system when we are talking about a shunt, or when we're talking only about a stent without connecting it to the shunt, so that we can connect the compartments of where the CSF is flowing together. So in a recent published study from Greifswald, this was also a conjoint work between Greifswald and Cairo University, but it was actually on adult patients, not on pediatric patients. Patients were collected from 1993 to 2013. We had like 526 endoscopic procedures with 25 procedures of stenting. These stenting, there were 8 arachnoid cysts. There were 13 cases with intraventricular tumors and complex hydrocephalus associated with these tumors. And there were 2 cases with stenosis of the foramen of Monroe. There is a marvelous case. I will show it just shortly. And 2 cases with aqueductal stenosis, and this dilemma that Professor Dr. Omar Youssef was just discussing. For the arachnoid cyst, in this, maybe in the early experience for Greifswald, they were using the stent to connect the cyst to the basal cisterns. Nowadays, it's not used. Actually, the stent is used when there is a fear or there is no guarantee that the fenestration will stay open. And because of the arachnoid cyst, it's most of the cases of the arachnoid cyst, maybe it's a low pressure cyst. So there is always a fear that the fenestration can close again. And this is why in the early experience, a stent was inserted or was implanted in order to keep the fenestration open. And in tumor cases, actually after excision of the tumor, just to connect the CSF spaces together in order to drain the CSF, as in this case, connecting the subdural space to the ventricular space. And in this case, where there is compartmental hydrocephalus inside the ventricles and then connecting the ventricles together, was done using a stent. This is another demonstrated case in this publication with a aqueductal stent. And actually, what Professor Omar Youssef was just discussing, this stent migrated afterward caudally in the spinal cord and beside the spinal cord, or beside the medulla in the cervical region, and it was left and ETV was performed. This is a case with the biventricular hydrocephalus. Rarely we have biventricular hydrocephalus where the 2 lateral ventricles are big and the 3rd ventricle is small. So this denotes occlusion or obstruction of the foramen of Monroe, or at the level of the foramen of Monroe. We see this often in oculoid cysts, but sometimes it's due to spontaneous obstruction, as in this case. This case, the foramen of Monroe was obstructed. It was not there. As we can see in this image here, where the question mark, this is the site where there is the septal vein and the choroid plexus, and this is where we have to see the foramen of Monroe, and it's not there. So actually, a stent was used in order to connect the lateral ventricle to the third ventricle with a very good follow-up, and this was published in 2012. And as a technical note, in order to prevent migration, even if the stent is not connected to a VP shunt or is not connected to a drainage device, we fix the stent to a burr hole reservoir in order not to migrate. So this is an important technical note that is used nowadays. Some recent cases that we have in Cairo University. So this was a case where the shunt was not that correctly posteriorly situated, and there was a kind of shunt obstruction. Actually, intraoperative, we just made sure that this is a ventricular. It was a ventricular obstruction, and that's why a shunt revision or a ventricular revision was performed, and this was performed endoscopically. As we can see, there is all ventricles are large, even the fourth ventricle. And from a CT, we cannot say if there is like adhesions at the level of the aqueduct or not, but we can see that all of them are large. So maybe this is a small video. We can see this is a sign of chronic hydrocephalus where the septum pellucidum is nearly not there. We can see the veins just hanging without any brain tissue. And then with visualization of the aqueduct, we can see that there's almost no membranes. So this is the fourth ventricle, and this is the aqueduct. So rather in this case, I just use the endoscope in order to insert the ventricular catheter so that it can drain, or it can remain draining the two large compartments, the fourth ventricle and the lateral third ventricle complex, because they are actually connected together. There is no floor of the lateral ventricle in this case. It's actually eroded from chronic hydrocephalus. So I can run it now, and as we can see, I only wanted to show the technique so that we go with the ventricular stent just parallel. And as we can see, there is a refashioning. It's very important to do refashioning in the ventricular catheter so that there will be holes in the two compartments so that it can drain the two compartments. And this is the follow-up. And the patient is doing good till now. So as we can see, this is the line of motion around the endoscope. Using the ventricular catheter, it doesn't move. The technique, it moves circumferential. So in order to avoid injury of anything, so we have to know that the ventricular catheter, when we use it beside the shunt, beside the endoscope, so it moves circumferential around the endoscope. So this is the line of movement. So that in order not to have any risky movement that can injure anything. So this is another case, and actually this is a case that may be parallel to the case before, because there might be some criticism why we can put it inside the aqueduct. And the answer is, why not? So yeah, maybe we can see that they are patent and they are open together, but it's doable. We can drain both compartments, and we can avoid that there would be nothing that can close these two compartments, and then we have this problem. This problem is a post-infectious hydrocephalus, and the patient had a VP shunt, a frontal VP shunt, and afterwards he started to develop a trapped fourth ventricle. So, and it was thought, this is actually one of the, or maybe it is the only proven still there indication to use an aqueductal stent, is the trapped fourth ventricle. So we have a problem now because the lateral ventricles are very small, and the shunt is doing well. Everything is drained, supratentorial, and we have a fourth ventricle, which is big. So how to put the stent? We know that the stent is the best way. So how to put the stent? So I actually thought to put the stent from occipital bare hole and going transcerebellar with the endoscope, of course, to visualize. And afterwards, we can reach that the stent actually is beside the draining shunt so that it would be connected to it. And then also refashioned so that the fourth ventricle would be connected to this, actually to this shunt. In multilocular hydrocephalus, putting the ventricular stent or the ventricular catheter of the VP shunt using the endoscope is crucial in order not to leave a compartment or a locule with increased tension and not drained. So maybe we have now like an exercise that we do always in Cairo University. We have like the image before the operation, and we start to see, we want to draw a line. Where is the optimal line that we can see the ventricular stent or catheter lying inside the ventricle? So before doing the operation, we have to draw the line. So we can draw a line like this, and then we can use navigation if we want. If it's doable without navigation, then we can do it also without navigation. Navigation is better when it's more than one locule or more than one compartment going to be opened. For sure, using the neural navigation would be of benefit. And this is the video. I don't think it's important, but actually we can just started by fenestration of all compartments and then putting the stent or the ventricular catheter. Also, it goes always circumferential. So that's why we have to take care about this. And then it has to pass through all holes or all fenestrations that were already performed. And it's a refashioned shunt so that holes can lie in all compartments. There is at least one hole in each compartment. And as we can see, the CT afterwards is, the patient is doing well, and this is the CT afterwards, and the ventricular catheter is lying as we planned. This is a case with a long-term follow-up, also with a morbid ventricular anatomy, epilepsy, and of course, increased tension, and the shunt was inserted also endoscopically. And this is the MRI after 6 months. Maybe it's overdrained, but actually the patient is doing clinically better. This is the campus from the University of Greifswald, where I took a big part of my learning. This is, of course, our home, Cairo University, Qasr Al Aini. This is the exercise. This is was sent from one of my colleagues yesterday in Cairo University. So it's drawing the line. He sent me this picture, and afterwards he sent me this picture, so that drawing the line where to put the ventricular catheter. So in conclusion, we can say that stenting is indicated when reliable and long-lasting restoration of the CSF pathway cannot be achieved without or with the endoscope, without using the stent, we mean. Stents are used to connect all ventricular compartments together in compartmental hydrocephalus. Refashioning of the shunt tube is a very important step in order to drain all compartments. And in treatment of tumor-related hydrocephalus, it's also a good option. Thank you.
Thank you very much. Thank you, Ihab, for this wonderful presentation. Professor Osama Al-Ghandour.
Good afternoon, everybody. I missed part of the first part for unforeseen reasons anyway. I just wanted to ask my dear Professor Dr. Ihab for two things. I've seen case of yours post-operative, a mass being taken out, excised very well, and then you try to make a stent and shunting. Every mass, we see a collection of subarachnoid, and by the time they disappear, why you do the shunt? The second question is, the case you shown lately, supratentorial ventricle are excellent, it's already drained, and the fourth is still dilated. What is the problem with that? We see that lots of patients, and they have nothing clinically, so long the supratentorial compartments are okay, and you know that the cerebellum tolerates such things, and clinically there is no attacks, and why should I do it? Thank you.
Thank you, Professor Osama, very much. Actually, it was a stent. If I'm just understanding right about this case with a tumor, this was not a shunt. This was in an adult case. It was excised very good, and it was put like a stent because the tumor was lying between the third ventricle and the lateral ventricles. So there was fear that there will be like an obstruction at the site of excision. So that's why it was put between the two lateral and third ventricle. So if I'm understanding right about this case, this was only a stent connection.
Okay, well, I've seen, well, it's mainly in the occipital horn or near the occipital region, and it's an excellent post-operative. And this subarachnoid collection and the site of operation, some CSF collections, they usually disappear. We've seen many cases like that, and we wait a couple of weeks or a month, they come back into normal. I just surprised why I put a stent.
I think you are talking about another case. This is the case with the subdural hygroma that developed subdural hygroma.
Do you want to share your screen again to show which case Professor Osama is speaking about?
This was increased tension. There was signs of increased tension in this case. That's why a stent was put. I think it was from the publication from this one.
Yes, this is the one. You see, yes. It's an occipital horn, occipital.
Yeah, yes, but the patient had increased tension. That's why it was put, and then this subdural hygroma was relieved afterwards.
How long did you post-operative did you do
that? Not a shunt. It's not a shunt. It's a stent.
Yes. How long? How long? And how long after surgery? The first surgery.
I think this was in the early post-operative, but I don't have.
Well, you see, that's what my expectation. If you wait for a couple of weeks, they will disappear. Because if you do large tumors, we see this normal quite often. You just wait for the re-expansion of the brain like a sponge, and being compressed by the tumor. Once you take it, it doesn't re-expand in a day. It takes few weeks to expand to normal. Anyway, what about the fourth ventricle dilatation?
Yeah, this patient he had an ataxia. He had ataxia. This child, it was there was some great disturbance and started to have ataxia. That's why. And actually, as far as I remember, the fourth ventricle was keeping dilating. It was small and then dilated and started to have some disturbance in walking. And that's why we were just decided to make this.
Mind you, that the cerebellum can be chopped half of it or markedly atrophied, and the patient is all right. I believe you that probably he has ataxia there, yes, but the problem always the supratentorial dilatation, and in your case, the ventricles up there are excellent. As I'm a bit surprised. I mean, if I follow you, I will bring you hundreds of cases of dilated ventricles, and clinically are okay. They have nothing.
Of course, yes. Of course, there are many cases with trapped fourth ventricle, and they don't have any clinical presentation. Okay. So that's why we don't have to do any operation for them. Of course.
Thank you very much.
Thank you, Professor Osama El-Ghandour, Honorary President of Egyptian Society of Neurosurgery and former Dean of Faculty of Medicine at Azhar University. Any other questions or comments?
Yes.
Omar?
Yes, Doctor. Yes. Thank you, Dr. Ehab, for this interesting topic. I could understand you used two types of stent approaches. The first one used the stent through an opened aqueduct to communicate the fourth with the other ventricle. That's good, and I think it's easy. But however, the second one, you use it. Do you use it through aqueduct stenosis? And what's your results regarding the stenting of diffuse or stricture or infundibular type? Thanks.
Yeah, thank you, Professor Omar. Actually, it's very tricky, this maneuver, to do occipital burr hole and go with the endoscope inside the fourth ventricle to look for the aqueduct upwards and see the stricture and open the membrane. It has to be done with navigation. It has to be done with navigation. It's very tricky, and it's has some risks. So actually, always in these cases, there is always like a plan B to put an occipital shunt in the fourth ventricle. We are always ready for this.
I think even a navigation would not be accurate, as you know, there is a shift in these soft tissue is not a bone, and I think the proper solution, if we this is my imagination, if we use a special dye and do an intraoperative MRI, or I think we don't have thin enough. For me, it's still I'm facing problem to know how I could go far with the stent, and how I could do it safely without injury of the brain stem. I think so.
Actually, you are absolutely right, Professor Omar. It's very tricky, but in this case, we had a very good thing that there was a shunt upwards, and there was also like a dilatation just caudal to the presence of this shunt. So actually, after I entered the navigation, of course, from downward in this dilated room, I saw the shunt there. So that's why I knew that I have to put the stent beside the shunt. So maybe it's a very exceptional case, but I did several cases from like this, and in many situations the operation was aborted after endoscopic visualization, and then we did a fourth ventricular shunt, additional one.
Professor Nelsey, do you have any solution or any proper management for a successful stenting or successful aqueduct plastic, or you still facing a problem as we face?
I don't have the magical solution. Is there difficult case? Yes, if we have ventricular dilatation, it's better to go for frontal downwards. But like the case Professor Eroff, he shows, when we have only posterior, the fourth ventricle dilatation and symptoms, we don't have too much options. The options are, or we put VP shunt or fourth ventricle peritoneal shunt, or we try to solve with the endoscope. The posterior fossa shunt leave us a lot of problems. I think the better is, like he shows to us, is try to solve with a customized catheter and try to connect with or VP shunt or reservoir, depend of the indication. But I agree, only stent without nothing to connect with is not a solution, is a partial step of treatment. But very difficult case. Congratulations for your presentation, Professor Ehab.
Thank you, Professor Nelsey. Thank you, Dr. Ehab, for this very interesting presentation. And now we proceed to our last presentation. It is an important presentation too. Professor Nelsey is going to speak about pediatric trauma prevention. Thank you.
Thank you for the invitation. Hope you are not tired.
No.
I have no disclosure on this presentation. and the pediatric trauma prevention, some prevalence, and some secondary injury prevention. The pediatric trauma is a very important issue. Every year, we have 1 million of children killed around the world. And most of these deaths are preventable. And if we are physicians, if you are leaders, we need to work on this field and try to decrease this number, not only for us, but for the humanity. Professor Schultz once tell me, Nelsey, if you would like to keep the people awake, take the home message at the beginning, because they are already tired at the end and nobody will answer. And the movie is at the beginning. We can stop here, but we continue. We have a little bit more time. For the World Federation, the Pediatric Committee, in the last 3 years, we worked in 2 fields. One is spina bifida prevention, and the second is trauma prevention. And thanks, Nasser, for give us this opportunity to speak on behalf of the Pediatric Neurosurgical Committee at the World Federation. We organized in 2018 SOLVE, Suicide, Accidents, Law, and Violence. Not only a medical or neurosurgical meeting, but with all the lawyers, the judge, the psychologists, social workers, and the school directors try to prevent trauma. And the last year we was in Recife, and December 15, we will be in Argentina, at this time online. And maybe after the conference, we can talk, if is necessary, in Egypt too, and try to work on this field. Injury, mortality, and morbidity surpass all major disease in children and young adults, but we don't pay too much attention because we are involved in very complex cases and our life is always busy. But we need to try at least to look behind if there is something that we can do more than we are doing now. And injury remains the most common cause of death and disability in childhood. For all traumas, pediatric trauma represent 25% of these accidents involving children. Is not a small number. And the road traffic are the leading cause of adolescent deaths in this period. And the USA have more than 10,000 children die for serious injury. We don't have all the numbers for each country. But the speed relationship with death and accident is already known. If we are driving in 22 kilometers per hour, the risk for the pedestrian accidents is 5% to be dead. And speeding to 64 kilometers per hour, the risk of death is 85%. And like a drivers, we need to pay attention like a citizen too. The road traffic accident rate, we have an idea, the countries maybe 20, 25 accident if each 100,000 population, the mortality rate is important on this group. But there is a special group for the neurosurgeons and trauma that there is each age of the child have a prevalence of accident. And below 20 months of age, the child maltreatment is the greatest majority of homicide in infant. We need to be aware for these numbers. And to try to identify this maltreatment and try to see what factors lead to suspicion to this etiology. The finding suggests maltreatment are the history of or physical examination. There is a discrepancy what the people are telling us, the parents or the family, and delayed presentation, and frequent prior injury of injuries incompatible with the developmental stage. We need to pay attention about the anamnesis, what they are talking about the accident, if there is connection or there is something that doesn't match. Retinal hemorrhage, bizarre injuries such as bites, cigarette burns, hook marks, skull fractures or rib fractures seen in children less than 24 months of age is not common, is not normal. Perioral or genital lesions need to pay attention also. And fractures of long bones in children younger than 3 years of age. These papers in 2017 suggest us that we need to have more critical evaluation and try to prevent this huge number that we even doesn't see in most of the cases. And is education again, awareness about prevention, the first trauma, at school or with parents and friends. The secondary injury, we need to pay attention at the beginning when we are treating these patients or in pre-hospitalar management, avoid hypotension, oximetry more than 90%, and try to pay attention that is children. But even though the ATLS, Advanced Trauma Life Support, since the 70s have the protocol that we need to do and to prevent the secondary lesion. It's the basic for those that work in the emergency room, A, B, C, D, and E. Is not the neurological in the front. We need to pay attention when they call us. Sometimes the drowsiness or the pre-coma are related with other abdominal or thoracic lesion. Like a neurosurgeon, we need to see back if everything was done correctly, not because we are the superhero, but because we need to pay attention that all the steps need to be done before to see the neurological questions. And the unique characteristic of the patients, the pediatric patient, are apnea, hypoventilation, and hypoxia occur 5 times more often than hypovolemia and hypotension. That these finds is more common in adult patients. And the brain development and maturation we have in the first months of life, it's very important. Try to avoid damage for don't have damaged brain for life. And the pediatric trauma need to be with all the professionals, skilled training in to pay attention in children's, because there is some difference that we can save lives when we are prepared to take care for these children. The most of the child are taking care in adults centers of reference. But when we are leaders and we have the possibility to build the new position, the new centers, maybe we can try to separate the adults emergency room for pediatric emergency room, and training people that the nurses, the pediatrician, the staff all are well trained to take care for this trauma patient when arrive in the emergency room. And to use the same scale, the same score, is important to talk the same language. For all the professionals have the same scale. For us, Glasgow is the more classical, but if they use another one, doesn't matter. The same score need to be used for all the professional involved and facilitate this communication. The mortality in patients can achieve 5%, but we have moderate disability in almost 20% of these patients. And these disability disorders can be later on perceived in the troubles in education, in comportamental disorders and learning disability. And we need to work with other professionals, try to improve this result. It's important to know that 90% of accidents can be avoided. And there is a non-governmental organization, Safe Kids Origin. We saw the video at the beginning. It's a Brazilian pediatric surgeon living in the United States. And during 3 decades, the reduce of the children death on trauma in 50% is a huge achievement. And this pediatric trauma prevention are this organization in 33 countries in the 5 continents. I have the privilege to work with them in Brazil. I doesn't see here Egypt, but if you are not on this organization, I will be very happy to introduce you and to put the pediatrician and the directors of the school to see this material is all available. You can translate, you can be in touch with them and put in our language to facilitate this communication. Just to have an idea, sure, it's not only because of this organization. There is a lot of medical association and politicians working on this field too. But the risk of injury was in accident 70% with 2 laws. The seatbelt law in 94 and the baby car seat in 19, it was quite recent. But it's very important to keep looking the data and to keep working on the field. Only in accident on these 16 years, the reduction are more than 30% based on the public data in Brazil. And the prevention stage on this organization is the E, the 6E. Education, engineering, enforcement, economy, and empowerment. There is all this definition and how the strategy can put in place. And this is a real picture. This is not from draw from somebody. It's real. We need to do more education that we are doing now. Just to have an idea, on this website, you can find each age, there is several particular prevention that you can avoid accident at home or at school or on the street. We just need to learn. There is other organization that I'm working with, is the Medical Women International Association. It's more than a century that the women medical are working on this field. And this year, the child health was on the first line. And the 10 recommendations to promote child health, I just choose some that are related with our work. Is spontaneous particular outdoor sports practice and prevention domestic injuries, prevention smoking and drugs abuse, and try to educate people for being more tolerant, non-violence, and preservation, nature and culture of peace since the early age for these children. And use the pandemic to nurture this attitude in ourselves. And let's together get more and more involved to promoting child's health like a mission. And there is something available right now, education. We can be the example and try to see and to promote safe environment, not for only our kids, but for our neighbors, for the school, for our hospital. And many countries reduce child injury death by 50% in the past 25 years. And just an example, if the accident just happened and the child became paraplegic, is not the end. He can even develop another skills and be a championship like Gabriel. It's para badminton, preparing for the Olympic Games in Tokyo 2020 that doesn't happen, but still training for the next opportunity to be a champion again. We are building with a small group, the Pediatric Neurosurgical .org is the website of Pediatric Neurosurgical World Federation website. We are just starting, but if you would like to collaborate with us, you are all welcome. Thank you very much for your kind attention.
Thank you very much, Professor Nelsey. Another very interesting talk, and I'm very happy to know that the Committee of Pediatric Neurosurgery at the World Federation, under your chairmanship, is doing such efforts in two important fields: prevention of spina bifida and the prevention of pediatric head trauma. Now we open discussion. Professor Sharif.
Can I start the question for you, please?
Yes.
Did you have a protocol or did you have maltreatment in child's trauma in your department or in your country?
Yes.
Okay. Professor Sharif.
I think the important message from the talk of Professor Nelsey is that we neurosurgeons should get more in contact with the different community sectors to raise the awareness about the importance of the injuries in the child age group and how they are or how they should be properly managed. And we have to offer all the facilities for this issue. Of course, we didn't reach a good level of the standard in caring with the maltreatment in Egypt here, but we are having active steps actually in this issue, and I hope in a short time we can reach a good level of child care maltreatment.
Omar.
Yes.
Ihab, do you like to make any comments? Ihab?
Yes.
A little comment, please.
Yes, Professor Osama.
Yes, I must thank Professor Nelsey for this awareness of child prevention from trauma and this. We've been working and seeing a lot of traumatic brain injuries in kids and children, and we noticed they do very well rather than adults because their brain can regenerate and because of brain plasticity. For example, we see cases with damage of the left cerebral hemisphere and patient changed, become left-handed of being right-handed. And by age, after they do very well indeed. I'm just surprised for the good prognosis and progress of the traumatic brain injuries in children and kids rather than when you compare that to adults. Adults, they remain crippled, they become vegetative, but in kids, really, very negligible number who remains vegetative or with permanent disability. That we see here. Do you have the same experience? Thank you.
Yes, thank you for your comments. Is the same experience, yes. And in the past, maybe 2 or 3 decades ago, the statement that if the child or the brain injury doesn't recover for a year, is lost forever, is not true anymore. We know the plasticity, the brain plasticity can happen even in adult patients. There is a Judy, I forgot the names, the neuroscientist that cured his own brain. She wrote that even 8 years after his accident, she couldn't recuperate some visual colors definition that she couldn't perceive during the previous years. Yes, I think it's important continuously work on this rehabilitation with a multidisciplinary team for these children.
Any other questions or comments? Ihab?
Thank you, Professor Nelsey, for this presentation. Actually, in Cairo University, despite that we manage the pediatric trauma in the trauma hospital, not in the pediatric hospital, but we have special preparations for these cases, either in the intensive care or in the operation theater or in the ward. Maybe several years ago, we tried to move the pediatric trauma to the pediatric hospital, but actually this was not feasible. And now we are doing everything affordable so that we can manage all these cases in the trauma hospital.
Congratulations. I think the most important is be prepared if it's in adult patients, but with the team prepared is fantastic because trauma, you need to have on call all the specialists and be aware with all the equipment, the ICU, and a lot of things need to be ready and you can optimize the team. Fantastic.
Omar, do you like to add any comments
Yes,
about Ain Shams University?
It's a very important issue. Dr. Nelsey raised this important issue, and I think it's a multidisciplinary plan. It should be through doctors, through universities, through school teaching, through media, through government. It's quite important and should be through a multidisciplinary. Even still, we face an unexpected trauma in adults due to lack of due to negligence, due to ignorance. Still, even in the adults and in the pediatric, it's quite higher.
Thank you, Omar. I think by this important discussion, it is time to close the webinar. At the end of this, it was a very successful scientific session about pediatric neurosurgery. At the end of this webinar, I would like to ask to thank our distinguished speakers, Professor Nelsey Zanon. She is the chairman of the Pediatric Neurosurgery Committee at the World Federation of Neurosurgical Societies. Thank you, Nelsey, very much for honoring us by giving 3 important lectures in our webinar. You are touching everything happening in Egypt. We have these problems. We would like to cooperate with you, to cooperate with the World Federation, and we are expecting for you much collaboration and much support. I would like to thank Professor Omar Youssef, to thank Professor Ihab Rifai, to thank Professor Sharif Izzat, who honored us by contribution to this webinar, Professor Osama Al-Ghannam. Thanks to all of you for contributing to this scientific activity and for giving us much of your time and experience. Thanks to all attendees. Thanks to Utopia Pharma for organization. Let me announce about the next webinar. Next Friday, it's going to be an educational symposium of the World Federation of Neurosurgical Societies. It's going to be African-Asian collaboration. We are going to have 12 eminent speakers and moderators. From Japan, we are going to have Professors Toshiki Akai Yoshimura, Satoshi Kuroda. From Africa, Professor Mahmoud Khorashi, Alan Taylor. From North America, Professor Robert Spitzler. From Latin America, Professor Nelsey Zanon and Samuel Zimberg. And at last from Europe, Professors Lucas Rasolik and Miguel Araiz. It is a big event. I enjoy everybody to contribute to this big event next Friday from 2 to 5 Egypt time. The flyer is already in the rotating banner at the World Federation of Neurosurgical Societies website. Thanks to all of you.
Thank you very much.
Thank you. Thank you. Thank you. Thank you. Right.